Okay then, let's have the coronary sinus lead then.
Hospitals are our acknowledged centres of expertise. They're where the NHS invests the majority of its annual budget. But as demand for specialist services grows ever heavier, something has to be done to ensure that only those people who really do need to be cared for in hospital are actually referred or treated there. And that when that happens, they're seen with the utmost speed. This programme reports on one initiative started here at Chorleywood Health Centre that, if taken up across the country, could well provide a solution to this complex and increasingly serious problem, which has blighted the NHS for so long.
I've got Mr. Green here so that we can talk about his ulcer and how we can manage his future, really.
OK, hello Mr. Green.
Good morning to you. Morning.
Now, how long have you had this ulcer for?
Mid to the end of March it started.
Right.
And this treatment started early April.
And what's happened to it?
Of course, telemedicine in itself is nothing new, but as it's been developed here at Chorleywood, it most certainly is. It's no longer confined to a long-distance consultation between patient and consultant in different locations using teleconferencing facilities.
Gradually getting better now.
Right. Is it very painful?
In essence, telemedicine calls for an entirely new approach to investigation and diagnosis, resulting in a change of responsibilities and consequently a change in the working relationship between the primary care team and hospital consultants and their staff. The man behind its development is the senior partner here, Dr. Russell Jones.
We're now talking about working differently, removing all the barriers between professional groups so that they can work together, become more efficient, do more things for the patient, particularly in the community before they get near the hospital.
I'm getting a very clear picture here, and it doesn't look as if you need to be referred to a consultant, which is the good news.
Okay, that's a very nice picture there.
Okay, just relax your arm down now and I'll do an office run and this will give you an idea of what it feels like.
Just to get you to wear this now for 24 hours, then this time tomorrow if you just take it off and bring it back to the surgery.
If you boil it all down and you look at it and you decide what on earth is going on here, I think really what you're talking about is you're moving the clinical data, that clinical data that says this patient has or hasn't got this illness, you're moving that data about between decision makers in healthcare, and you aren't moving the patient around.
But in order for the GP to move the data, if that should prove necessary, the data, first of all, have to be collected. And that's where the real difference in approach between Chorleywood and most GP practices, mine included, becomes apparent. Apart from the teleconferencing suite, this place is fitted out with all sorts of specialist equipment that you'd normally expect to see only in a hospital. And what's more, the staff, the GPs, nurses and physiotherapists who work here have been trained to use specific pieces of it. Between them, they carry out a whole range of tests that can assist in or confirm the diagnosis of some of the more prevalent diseases that normally require the intervention of a hospital specialist.
Did he have any symptoms when he was having the 24-hour take?
No.
And it's then, and only then, after the results have been analysed and following a referral, that the teleconferencing side of telemedicine comes into play.
Heather, are you happy with how it's going in terms of healing?
It seems to be doing really well. It was very, very deep, so it's come up quite nicely.
And surprisingly enough, that crucial element, the actual consultation, doesn't always involve the GP. That's because the usual hierarchical structure, which one would expect to see in a GP surgery, doesn't exist here. So, for example, the 3 specialist nurse practitioners share total responsibility for all the vascular patients. Sister Heather Francis is one of them.
It doesn't involve the GPs at all. We have learned how to assess, refer, do the referral letters, do the workup, book in the date for the link and link with the consultant, which means that we actually have that interaction with the consultant where normally we wouldn't see them at all or know the outcome until a good few months down the line.
And not only is that an example of an excellent use of resource, it's also highly motivational. The major beneficiary of this approach, though, is undoubtedly the patient, and the major benefit is speed. Speed of both diagnosis and consultation. Alan Price-Davis, who went to the surgery complaining of a pain in his chest, has every reason to be grateful for the availability of a local stress test.
The way and the speed in which the tests were done meant that I was able to see the consultant and that he had the benefit of the tests in front of him when he saw me.
Right, Mr. Price-Davis, the patient who I sent the letter about and the exercise test beforehand.
Good afternoon.
Good afternoon, Mr. Price-Davies.
He was able to see those tests and to see me on the link within a matter of 8 or 9 days of my first having gone to see Dr. Jones.
Can you show me in your chest whereabouts you get the pain?
It's more or less dead centre, right here.
Right. And does it move into your arm or in your jaw at all?
Not really, no.
The referral isn't a referral of symptoms. It's not a referral of a bit of chest pain. It's a referral of, yes, chest pain, but also here's the evidence that the chest pain is to do with heart disease and with arterial narrowing. Next step, please, which is investigate further, and soon, hopefully.
Now, when you did the exercise test the other day, the result of which I can see here, did that bring on the same pain as what you've been having?
Very much so, yes.
I don't know how much Dr. Jones has told you about what we've seen on this, but we are seeing some ECG changes when you exercise, which are very suggestive that you may have what we call angina.
Oh.
We had the information up here. His exercise test was available, which was obviously positive. I could scroll through his medical history online to see what had happened in the past. And I think we've come to a good diagnosis, and the patient's aware of what the action plan, so to speak, is and how we're going to take it forward.
That meant that I did not have a serious heart problem, in that I didn't suffer a major heart attack and there was no damage to the heart muscle. That really is the difference between life and death in many cases, because with 95% narrowing of the main artery, it could have gone either way.
A sobering thought. But the benefits to the patient aren't limited to a rapid diagnosis and consultation. Howard Green has a leg ulcer as a result of diabetes. He's wheelchair-bound and finds travelling to and from hospital a disturbing prospect.
You've got to appreciate that with my disabilities, travelling is not easy in the first place. And also, if I had to travel any distance, then I would get rather tired as well.
Can I have a look at the leg now?
The fact that it can be done just round the corner is very convenient.
Heather's experience of patients' reactions confirms this.
Is that clear? Yes, that's fine.
Firstly, they don't have to wait for their appointment to see the consultant. They don't have to wait all day in the outpatients department. They don't have to wait for transport to get them there and back. And then they don't have to go again for tests and then again to see the consultant for the results with then the outcome of what treatment they're going to have. That's all missed because that's all done here, which is local to where they live.
I think the person who gains most out of this is the patient themselves. They avoid the travel and the worry and the concern about coming up to a strange place and meeting a strange person. They can do it in the comfort of their own community, surrounded by people they know, who can then talk to them about it afterwards, because they've been there as well. By taking the pressure off, we can get it to heal a bit faster than it is healing at the moment. Even though it's doing quite well, it would give us an idea of whether that was part of the problem.
Because you've got no feeling down there, it's important to relieve the pressure.
Yes.
So
it was definitely helpful that she was there, because got hearing aids as well. I didn't always hear what the consultant said, and Heather sitting next to me repeated it and made sure that I knew what was going on, yes.
Bad enough. That's bad enough. How does the chest feel? It's just started joining.
A lot of patients get very intimidated coming to a hospital, and particularly coming to see a cardiologist. They're generally very worried. They've got potentially a serious problem, and it's their heart. And many times patients will come along and be so anxious that they are unable to give you a good history. Their blood pressure is sky high, and often they'll forget to ask you things that they wanted to ask you. Whereas if they got their GP, and to whom often is a friend of theirs, they can sit and discuss this with you in a far more relaxed and meaningful way.
Well, if you look in cardiology, and you talk to the consultant running a clinic, a busy clinic with a long waiting time, what are they seeing? What are they looking after? And they say, well, palpitations often, they've waited for many months to be seen in the clinic, and they're not ill.
It does seem crazy that patients come all the way to the hospital to have a monitor fitted, to return 24 hours later to drop the monitor off and never see a doctor or anyone at that stage. All they're seeing is the cardiac physiologist.
They need a recording done, but that recording could be done In a general practice, it doesn't have to be done in a hospital. And if it's negative, it's negative. If there's no pathology there isn't a problem.
But negative or positive, when the procedure is carried out by primary care staff, it saves a considerable amount of hospital time.
If it stops and taking the pressure off hasn't helped, then I think what we'll do is arrange a scan of the veins.
But that would mean coming across to Oxford, and if we can get it to heal without doing that, so much the better.
And Dr. Hans acknowledges another benefit that greater use of the primary care team offers the consultant.
What it also allows us to do is to triage cases, if you like, to find out important points about them. First of all, is it a vascular problem as far as I'm concerned, or should they be seen or investigated somewhere else? If it is a vascular problem, does it actually need anything doing in the hospital, or could it be treated in the community by the practice nurses? Heather, is it possible to arrange something before Mr. Green goes, do you think?
I will certainly try.
If they do need to come up to hospital, then we can decide ahead of time exactly what they need doing, so we can minimise the use of hospital resources, minimise the use of outpatients and hospital transport. So all those things we do save on. That's great. Just hold it there for a few moments. That's beautiful. Good.
But the closer working relationship which results from telemedicine also has an educational benefit.
We're working together to treat the patient. And at the same time, they're learning the techniques that I use to assess the patient, so that they can use them themselves to spot a patient who perhaps has arterial disease or venous disease.
If you take, for instance, chest pain, I would ask the patient, does it last seconds or minutes? Now, if the pain lasts seconds, it's highly unlikely to be their heart. And perhaps next time the GP would ask the patient that question. The patient says the pain only lasts seconds. You think, well, it's not his heart, I'll think about something else.
There's an educational element to both ends. I learn what they can do, what they do, how they manage the patient, and they take a note of what I suggest in terms of management of the patient.
What can you do about it?
Well, what we'd like to do is to arrange for you to have what's called an angiogram, where we...
But as you'd expect, telemedicine isn't regarded as a panacea that will remove the necessity for a consultant ever to see a patient face to face. Dr. van der Watt.
It doesn't replace the hospital consultation, particularly in patients who've got valve problems or heart failure. I can't look for certain nuances which I can do on a face-to-face consultation.
It may well not work quite so well, where you need to feel something, feel the temperature, to feel the texture of something.
I can't see if the patient is anemic, I can't tell if the patient's cyanosed, I can't look for signs of high cholesterol in them.
You can ask a nurse to do it, but it's not quite the same. And I think if it's something quite subtle that you're looking for, it really would be quite difficult.
But in a situation of, say, angina, where the examination becomes less important. It's more the history and the and the tests results that are important to us. Most commonly these days we can treat these with what's called angioplasty.
So, as Dr. van der Watt readily admits, the availability of telemedicine means there's no need for patients like Alan Price-Jones to wait weeks, or more likely months, to see a consultant. It can all be achieved to his usual high standards and complete satisfaction down the line. And Dr. Hans sees another advantage.
We know exactly who we're going to see and roughly how long they're going to take, so we can be rather more efficient, I think, than conventional outpatients in scheduling the patients.
And the main reason for that?
Well, I suppose one of the big advantages is that the patients tend to attend the clinic. We don't get too many DNAs.
Unlike conventional outpatients, when maybe 20% of the patients on some occasions might not turn up because they've got problems getting to hospital, or they haven't had the appointment through, or they've had difficulty parking the car and they've given up and gone home in disgust.
So, with some obvious and understandable reservations, telemedicine gets the thumbs up from the clinicians. But how's it viewed by the PCT's executive? Felicity Cox is the CEO.
This initiative is important because it gives us the opportunity to focus resources around the patient. It gives us the opportunity for patients to be involved in their healthcare together with their primary care practitioner, which means both the primary care practitioner and the patient are part of the education process and part of the overall disease management process.
But would a wider take-up mean that all GP surgeries would have to be equipped like this one at Chorleywood?
I don't think it would be appropriate for every practice to have that kind of technology.
I see people collaborating, more and more practitioners, and I'm talking about general practice in the community and other community services.
What we're looking at already is to set up community hubs where a number of general practitioners would feed into that centre. And it would be things like community echo, community exercise testing, 24-hour ECGs, 24-hour blood pressure monitors.
But all will be linked. All practitioners then will be linked, and will have a way of getting hold of that information or requesting that information as they need it to make their decisions, support their decisions.
And whether the tests get analysed on site or sent through to the tertiary centre or the secondary centre to have the analysis done, we are progressing with that.
So, with consultants and GPs sharing an exciting view of the future, let's hear from the GP who has ultimate responsibility for primary care, the Director of Primary Care, Dr. David Colin-Tomey. What's his reaction to this initiative?
Well, I applaud the fact that the patient is going to be the big winner in this. These extra resources are going to make care so much better that you don't need to travel. You don't need to wait to the long lengths we had before. This can be done locally, effectively, diagnosis made in the community. Big difference to care.
But the actual core business of looking after somebody who is ill is no different. You're making a presumed diagnosis, and I suppose what we're doing is hardening it up, putting some certainty into it with the data.
If we could spread the good work that's being done in Chorleywood around the whole country, the benefits for patients would be immeasurable. Far more rapid care. It would turn on a lot more people working in primary care, it's a more fulfilling job, and we'll use resources more effectively.
David Colin-Tomey. And having seen how telemedicine works and what it can do, that's a vision I can share.